Excellent. If you change your mind, I gotcha.
Okay, good.
Okay.
Good morning, everyone. Looks like there's a couple of people still trying to get on, so I'll give them just a little bit of time and then we'll get started. All right, we'll get started. Hey, good morning on this beautiful March morning. My goodness, it's gorgeous outside. It's a far cry from the last time we got together because it was frigid, if you'll remember. Maybe some of you have blocked that out of your minds. I have. The sun looks great, feels good. So hopefully you'll be able to get outside for just a little bit and enjoy this wonderful weather, because of course it's going to change. Thank you for attending this Telemedicine Echo. The Heartland Telehealth Resource Center and the Missouri Telehealth Network have joined together to bring you this Echo for providers in Missouri, Kansas, and Oklahoma. And we'll address topics that include all things telemedicine. We're so glad you're here. So I'm Janine Gracie, Project Director of the HTRC, and I have the honor to moderate these sessions. Before we get started, I'd like to ask everyone on this Echo to rename your Echo screen to show your first and last name and your state abbreviation. And the way that you do this is that if you're at your computer, you right-click on your picture or your name, go down to rename, and then some of you just need to add your state. So I'm going to do that while we wait for everyone else to do that as well. And that way we know how to answer your questions, because of course, you know, every state's just a little bit different, and we want to make sure that we answer the question appropriately for your state if those are questions that come up. So thank you for doing that. Wonderful. All right, so let's introduce the Hub team members at this point. We're going to start with Rachel this morning.
Good morning, everybody. I'm Rachel Mutro, and I'm the director of the Missouri Telehealth Network and Show Me Echo program. And I'm also the state representative for the Heartland Telehealth Resource Center.
Thank you, Rachel. Good to see you. Karen Edison from Missouri is out today, and so we'll go to Evelyn.
Good morning. Great to see everybody this morning. I'm Evelyn Nelson. I'm a psychologist at KU Med Center and PI for the Heartland Telehealth Resource Center.
Thank you, Evelyn. Great. Tim from Oklahoma.
Good morning. Tim Davis, OSU CHS Telehealth Manager and the Oklahoma contact for HTRC.
And Heather.
Good morning, everyone. My name is Heather Hagan. I'm a telehealth analyst at OSU CHS.
Great, thank you, Heather. Usually we have Robert Stiles on. He might be out, or he might be just trying to jump on. So he's also a member of our Hub team. So since we have this number of people, we can go ahead and have you guys introduce yourselves. And I would like to start with Lori.
I am Lori Spar, family nurse practitioner in Waynesville, Missouri. I work for Central Ozarks Medical Center.
Thank you. Very good. Jerry.
I'm Jerry Wilmus. I'm a physician based in Maryville, Missouri. And like many of you, I just kind of do a lot of odds and ends. Can't find anything I do very well, so I just keep trying.
I don't believe that for 1 minute, Jerry. Nice try, though, right? All right, Dean.
Good morning, Dean Anderson, one of the outreach coordinators for the Show Me Echo program, and always interested in hearing ideas you might have for increasing participation.
Great, thank you so much, Dean, for all the work you do. Lindsay.
Hi, good morning, everybody. I'm Lindsay Beckman. I'm the Associate Director of Outreach and Education for the Show Me Echo team. Nice to see you all.
Thank you, Lindsay. Thanks for your work. Cece.
Good morning. Thanks for being here. I'm Cece Bengal, your telehealth coordinator with Missouri Telehealth Network and Show Me Echo.
Cece keeps us organized. Thank you so much for all you do. Emily.
Hi, I'm Emily Hunt. I'm a licensed clinical social worker, and I am a program manager over at Rediscover Behavioral Health in Missouri.
Great, Emily. Thanks for joining. Trika.
Good morning. I'm Trika Young, and I'm one of the outreach workers here at Missouri Telehealth Network. And as Dean has stated, we're always interested in looking at opportunities to promote the ECHO program. Thank you.
Thank you, Trika, for all you do. Christy.
Hi, I'm Christy Gagne. I'm a telehealth communication manager at the KU Medical Center, and I also help with some of the HTRC communications and projects.
And help she does. She's awesome. Thank you so much, Christy. Mila.
Good morning, everyone. I'm a retired physician in Columbia, Missouri, interested in this topic.
Thank you so much for joining us. We appreciate your participation. Tammy?
Hi, I'm Tammy Day. I'm a DNP RN and the manager of the Clinical Research Center at University of Missouri School of Medicine.
Thank you, Tammy, for joining us. Sarah?
Good morning, everyone. My name is Sarah Stills. I'm the founder of a virtual healthcare clinic called Prime Movement Healthcare. We're actually based in Indianapolis, so your promotion of the Show Me Echo program has been going well if it reached me. We're actually looking at adding telehealth PT sometime in 2022. So when I saw that this was being offered, I thought, well, yeah, that makes perfect sense because all of our other programs, diabetes prevention, diabetes management, cardiac and pulmonary rehab, are delivered via telehealth.
Well, Sarah, we are so glad that you're here. Thanks for joining us.
Thanks for putting this on. This is incredible.
Great. Thank you. Shelley. Shelley might be having trouble getting unmuted. So let's go ahead and go to Travana.
Good morning, everyone. I'm also a licensed clinical social worker in the state of Missouri. I'm also the behavioral health manager at Kansas City Public Schools, and we implemented telehealth actually this school year in response to COVID so that we can ensure that our students and families had access to quality telehealth services. And I see Dr. Cooper is on the call as well. She was instrumental in helping us implement our telehealth services.
Wonderful. We're so glad that you guys are here, and we'd love to learn more about how things are going for you. That's wonderful. Robin. Oh, Robin disappeared. Okay. Rita.
Good morning, everybody. My name is Rita Maldonado, and I work with the Health Resources Services Administration, or HRSA. And I am so grateful for your including me. I always learn so much from this group.
Well, we are so glad that you're here, Rita. And T. Smith. Might be having trouble unmuting as well. So did I miss anyone? Because things kind of shifted on me a little bit during those introductions, and I want to make sure that everyone has the chance to introduce themselves. But it looks like we have it. All right, so now, last but not least, I will introduce Sharon Lynch here shortly, but want to go over just a few a few business items, if you will, during this echo. Most of you have joined us before, and that's great. So we appreciate that, but there might be a couple of newbies. So we want to go through some of these announcements that we usually give. So for a more interconnected environment, we always use first names. We don't get hung up on titles. So, you know, we just use first names, and make sure you do that when you ask a question or when you address someone. So please be conscious of any confidential information that you might share. If you have a question that is about a patient, make sure that, you know, you keep that confidential and protected information to yourself, and that way we don't break any rules. If you have a question, you may raise your hand and ask that question after the didactic is over. And or if you want to make sure that you don't forget your question during the didactic, you can also type that out in the chat. So either way is fine with us. Keep your microphone on mute until you're ready to speak. And remember to introduce yourself if you ask a question. And this presentation will be available on Box. And surely most of you have accessed Box before and can remember your password. You know, I always have to think about that before I get on there. But if you haven't been able to access these presentations, please let Cece know. She can help you get through you know, that registration process and get into that, because there's a wealth of information in Box about these telemedicine echoes, and we don't want you to miss out on that. So our speaker today is Dr. Sharon Lynch. She is the clinic director for the MS Achievement Center, and she has been involved in multiple sclerosis research, patient care, and teaching for more than 25 years. She came to the University of Kansas Medical Center in 1991 to start a new MS clinic, and her vision has guided this organization since its inception and continues to move it forward into the future so that it will serve people with progressed MS. And we are so lucky to have her here to share her knowledge about telehealth physical therapy. So Sharon, I am going to give the program over to you.
Okay, well, I'm going to tell you about a program or a pilot study that we are doing to try and leverage telehealth to improve the physical therapy experience of people with multiple sclerosis. So I'm going to try to share this screen here. I hope that I'm able to do this. Does that work? Can you see it?
Yes, ma'am. We've got that. Good job.
Good. All right. So basically, we have created a program to evaluate the usefulness of physical therapy specialty service models in people with multiple sclerosis in rural communities. So the problem is that it is having physical therapy specialty is very important to people with multiple sclerosis. The National MS Society has identified that we need people with MS to have access not only to healthcare, but to healthcare providers who have some knowledge of multiple sclerosis. And for people to be able to understand multiple sclerosis better, to get better professional development in the area. Of course, the problem is that a person from a rural area is going to be interested in a number of different topics because they are going to see a smaller number of people with MS, and they're going to be seeing large numbers of people with all kinds of diseases. So they can't go out and become an MS specialist because that doesn't serve their community. What serves their community is for them to be a generalist. But physical therapists in rural areas become overworked. They have limited experience with people working with people with MS. And they complain sometimes about the limited ability to consult with experts and that they don't have good access to professional education. So, only 16% of people with MS live in rural areas. So, and as I said before, a patient load in a rural practice includes a variety of different illnesses. A PT may see only a few individuals with MS in a year's time, and they're going to be spending a lot of their time dealing with orthopedic issues or other things that aren't even neurologic. And so there's a need for them to do well with a number of different disease processes, but they do need to understand the physical problems of the person for which they are serving. And the other problem with MS is that MS is not very uniform. So with people with Parkinson's disease or ALS or diseases like that, there's a certain uniformity to the problems that they have. Where with MS, it can be all over the place. It can be a tremor, it can be a hemiparesis, it can be a paraparesis, it can be just a little bit of weakness of a limb, it can be an incoordination of gait, it can be weakness, it can be numbness. And so each person needs to be approached as an individual, and you can't just walk in and say, they have MS, this is a set of exercises they have to do. So we were trying to figure out how best to leverage telehealth to help people in rural areas get better physical therapy experiences, both the physical therapist and the patient. So traditionally, we've used a lot of telehealth for an education program where we would go in and we would do a program. This is how you deal with people with MS for physical therapy. And of course, that's not very individualized. And a lot of times a busy rural person will get on one of these telehealth conferences. They'll be on it for, a few sessions or a session or two. And then they won't see an MS patient for 3 months, by which time they've forgotten a lot of what they were told in the meeting, or they have to try to find notes, or it's not immediately effective in their immediate practice changes. And of course, anything that you sit around and wait to do you don't get as much out of it. So, but with the current telehealth process, you can actually do a lot of things in real time, and we don't have to do things in a structured course of 30 people. We can also do one-on-one types of training. So we decided that we would try a one-on-one approach to the physical therapy model in this case. So, an advantage to a consultation, what we're doing is a single consultation with a single patient with the physical therapist. So this has a big advantage. One is the patients can be served in their own community. They can have a short commute time. They can still have a local PT who actually does hands-on physical work with them, because unlike many other things where you're just talking about what you're doing, you actually do need to sometimes put your fingers on the person and help them feel what you're feeling, feel what their spasticity feels like, help them to walk better, help them to move better, demonstrate things for them. So that physical piece is still present. And also we support the local community and its services by allowing the local PT to also be a part of this process, rather than just taking over and becoming this central system. So, so this project is mostly a feasibility project. We're looking to see, is this something we can do? So, so our 3 aims were to determine the feasibility of comparing 2 treatment models supporting a PT, one with written recommendations and the other with written and telehealth consultation. To determine the impact of MS-specific PT recommendation and consultation on therapy outcomes and satisfaction of people with MS with their physical therapy, and to determine the impact of telehealth consultation on the PT's confidence in their ability to treat people with MS. So essentially we have two subjects in each interaction, the patient and the physical therapist. So we are recruiting 15 people with MS who need PT services. And we are also recruiting their physical therapists. These have to be people who are in a rural area, so that, or outside the big city essentially, so that they don't have access to people who have more of an experience with MS. The people with MS choose their own PT. Once the person with MS chooses their PT, then we reach out to that PT to talk to them about whether they want to participate in the program. Subjects are randomized to one of three groups. One is a control group who receives PT orders written by their MS neurologist, and they're sent forth. The second group receives the orders and they have an evaluation with a KU-MC PT who has experience with people with multiple sclerosis specifically. And the third group receives the same PT orders and receives the consultation note from the PT, but also works with that PT in a telehealth type of setting to consult on that one individual patient. So in these consultation sessions, they have 6 sessions. They'll do one session where they discuss the person with MS and their needs prior to the time the PT sees them. And then they have a second plan after they've met with the person to discuss the treatment plan and specific intervention techniques. Sessions 3 through 5 will do a content, are kind of determined by the therapist and the person with, and both the treating therapist and the consulting therapist. So they kind of work together 2 or 3 times to discuss this case. And then on the 6th session, they finish, after the patient finishes their PT, they have a session discussing the outcome of the treatment and how that went. We've been able to provide CEUs for the PTs who participate in the telehealth consultation that can be applied to their Kansas license renewal. So what the PT gets out of it, aside from learning, is that they actually get to use continuing education credits as well. So we began enrolling in March of 2020. We've enrolled 12 people to date, and with 10 different PTs and PTAs. One person with MS is on hold due to concerns of contracting COVID. One person with MS has been on hold waiting for insurance to change. She felt like she needed to have a different insurance, and she was waiting for the change before she did all of her physical therapy. One withdrew because the company for which she worked felt that they needed a contract between KUMC and us in order to do this program. I'm not quite sure what their reasoning was, but anyway, they declined to participate. And the other people have participated. We've had quite a few different regions in Kansas, and we've had essentially been able to randomize it evenly between the groups. So we have 4 in each group. Study enrollment was unfortunately on hold for 3 or 4 months while we were dealing with the COVID research policy. We had to modify the study to allow for virtual enrollment of people with MS for visits 1 and 2 assessments. So the physical therapist was the consulting physical therapist here has been able to do her assessments through telehealth online instead of seeing them in person if the patient was not able to be here. That has actually turned out to be a benefit, not just for the COVID, but for practicality in real life. Because when we recruit a person, then we need to call the physical therapist to come and evaluate the patient. And sometimes that physical therapist is doing other things. Since I see patients 5 days a week and I can't really predict when the person is going to come that we are able to use, the physical therapist will not always be able to just drop whatever she's doing and come down to evaluate the patient. But if we can use telehealth, then I can recruit the patient, order their physical therapy, and then she can contact them later to do her consultations. And she can contact the PTs virtually, and then we don't have to have, we've been able to do virtual consents and things like that. So the patients don't actually have to be physically in the clinic in order to participate in the study. But we did have one person who was not able to enroll virtually because she could not, she did not have internet connection. She did not want to have an internet connection. And one person decided to delay initiation of physical therapy and MS clinic visits due to COVID. So what have we learned so far? Well, rural PTs, which have been enrolled, have had access to technology to participate in the telehealth consultation. So in that regard, what we've shown is that we do have the technology to do this for the most part. Every physical therapist approached about enrolling it has met the self-reported inclusion criteria of limited or no MS treatment experience. Recruitment has been very slow, partially because the number of patients who qualify for the study is relatively small, because basically we need not only a person with MS, but a person with MS who needs PT at this time. Because when we are seeing a patient, you know, sometimes they need PT services and sometimes they don't. And it's also difficult to have the KUPT on site for the small numbers of patients who qualify, and the modifications of using an initial assessment through telehealth have been a way of allowing us to continue to recruit with limited resources. So far, the PTs in the control group have indicated that they wish they were in group 2 and 3, and I will tell you that the patients in the control group have also felt the same way. The PTs have had difficulty finding time to participate in telehealth sessions, and that can be a challenge. The PTs have appreciated the input of the KUMC PT in both formats, and the PTs in group 2 and 3 have reported increased comfort with MS for future MS patients in the current group. Patients experienced the people with MS have been pleased with their outcomes and their relationships with the treating physical therapist. And I think that the strength of sort of a collaborative approach has been beneficial to the people with MS. So future plans. Well, when we began this, we chose to be only part of only do the Kansas system to try and work through Kansas. We have since been able to contact some of the Missouri PTs and discuss the idea of CEUs for Missouri physical therapists as well. So we will be expanding our reach into Missouri. However, we're going to, in order to expand the study to a larger cohort, we're probably going to have multiple centers to do this work. So we will probably be reaching out to centers in other places that serve rural communities, such as Nebraska and Oklahoma, and possibly Colorado. The model itself seems to be well received, and the addition of the telehealth consultation has been of benefit to just that piece alone has been really beneficial to our recruitment and also our ability to make the study go. So in that way, the pilot study has been successful in identifying the issues that we need to address. And we hope to expand the study to a larger cohort in the future. Thank you.
Thank you so much, Dr. Lynch. That was wonderful. So questions. I think we have a question in the chat that we can have you answer. Do patients and therapists need to be based in Kansas, or can they come from adjacent states? Well, you answered that somewhat, but are you just thinking of Missouri or any other states?
So right now, we have to sort of, in order to deal with the CEU issues, and the physical therapy programs are all kind of set in by state. In order to use somebody, say in Oklahoma, we would have to reach out to the physical therapy associations in Oklahoma, the licensing bureaus, in order to help get the CEUs. So that's why we originally just went to Kansas. And then we recently talked about doing Missouri because, we're on the border. And so that seemed to be the logical place to go next, is to talk to the Missouri people. My clinic itself serves mostly Kansas and Missouri. I do have a smattering of people from Oklahoma and Arkansas. And I think I have a few from Nebraska. So, theoretically, we could work with those people as well. We also could, and my hope is to do this as a larger project. And if we do, I would want to say reach out to the MS Center in Nebraska, in Omaha, and the one of the MS centers in Oklahoma, and perhaps in Columbia, and try to enlarge our reach. And actually, I may look into Illinois as well. There's actually quite a bit of rural area in Illinois that might be interested in this sort of project. And I know a few people in Chicago that do, because the problem is, for an MS center, somebody who really focuses on MS, you're going to almost always be in a big city. And then the people in rural areas usually come to us or contact us, work with us to get their care. And when you get care, when you get care from a neurologist, it's not that onerous to come to see us once every 6 months or once every year. But it's pretty onerous to do physical therapy when you're supposed to go 2 and 3 days a week. That's just really not possible. So when they do the therapy this way, they can still do this locally. They can still have a hands-on person. They can have a person who's looking at them and physically working with them, but at the same time, and support their local community, their local physical therapist. But at the same time, the consultant from Kansas City or from Chicago or from wherever can sit down with them and say, well, my vast experience with MS patients says that this is probably a better way to go. So
yeah, it's just a win-win-win situation for everyone in that aspect when they're able to stay in their own communities. And that's what, one of the benefits of telehealth is to make sure that we keep our patients in their home communities. Yeah. Questions? Any other questions? Don't be shy.
Great talk. I wondered what the role of the primary care provider is with some of the work. I think about the primary care we work with, and I think they'd be so excited.
So that's a good point. I have so far used the model of having the physical therapy order be through the neurologist that doesn't necessarily have to be the case. Certainly in a smaller community, a primary care doctor will often see a person who's struggling with their MS and will choose to order physical therapy. And when they do that, the person will often need the same thing happens. The local physical therapist spends a lot of time doing knees and backs and hips and sees the occasional MS patient. One thing that I also do want to do is I think the same model can be used in occupational therapy. So it's not just physical therapy, and perhaps even in speech therapy particularly, so that we could again get some help assist people of other disciplines to do the same thing. I chose physical therapy because it was low-hanging fruit. It's it's something that a lot of people need, and we do a lot of in our care.
Yeah, all those others, the OT and speech, that's really exciting.
I also want to thank you for your presentation, Sharon. And I guess I want to take the flip of the question that Evelyn just asked. And I think you probably know this, but in this group, I think it's fair to say you're preaching to the choir. We just think telemedicine, there's untapped potential in so many areas. So my question is, have you run into the opposite where it makes perfect sense to do it, but either a referring physician or somebody else in healthcare says, well, that doesn't seem like that's going to work, or any challenges that way?
So the only challenge we had was this group in the Wichita area that basically said, oh, we can't do that without a contract.
Right.
Even though no money is changing hands. In this case, we are providing this service for free. I'm eating the cost of it all. Basically we're just trying to see if it works. And so we're using essentially research dollars, which in translation at the moment, since I don't have funding for it, means that I'm footing the bill.
So it was really a legal and contractual obstacle versus somebody saying logistically, I don't see how this can work. Is that right?
Yeah, that's right. I really believe, and I know I'm probably preaching to the choir, but I believe that MS is such an individual disease that to have somebody try to give a lecture on how to treat MS patients and then have them then go out to do this, 3 months later, see one patient, or even see one patient even with this system and think that they now know how to treat MS patients is kind of ridiculous. And so this model allows essentially an apprenticeship type of training, a one-on-one type training. And the PT then does learn things that they can apply to other patients. That's really valuable, but it's also true that they now have somebody to lean back on to help them with the next patient. I'm not sure, one of the things that I've focused on rural areas and distance, but particularly in these COVID days, it's possible we might want to think about whether that same model might not be used even in smaller PT offices in closer to home, but who basically spend most of their time doing orthopedic types of therapy, and who would like to know more about how to do neuro rehab without having to go to class. One of the challenges has been that the PTs themselves sometimes say, this takes a lot of time. So, because while we're not charging them any money, it does take them the time to sit down with that PT and evaluate it afterwards. And that's time that they're not spending with another patient and being billed or billing.
How about the equipment that you're using? I mean, is there a preference by the PTs in terms of what's more easily used or what they appreciate more? And do they have their own, or did you have to send?
So I think so far we have had our own. I mean, they have had their own. We have 2 iPads available. So we will send the patient out with an iPad if they need it to give to the PT, that the PT can then, or that we'll send out the PT, an iPad, and then they send it back or give it back to us. But so far, I don't think we've needed that. The technology these days is out there for the most part. That's one of the things that's kind of cool with the newer systems. It used to be, okay, I'm going to do telemedicine. I have to go to a special room in a special place, and the patient has to go to a special room in a special place, and they still have to have travel. And now it's more like, well, get your computer out, type in a few things, sit down at it, and we'll have a chat.
Exactly. It makes it a lot easier, doesn't it? Yeah. What about PT as a reimbursable code in the state of Kansas? Do you see that changing anytime soon, or have you heard any scuttlebutt?
I think it might change, but right now it's not. Telehealth PT is not. And I think that is going to be one of the challenges if this type of system is adopted, is that at some point, the consulting PT is going to want to be paid. If this becomes commercial, the consulting PT is going to want to be paid, as well as the person who is on the ground doing the job. So it will require some payment system to allow it to become any kind of a universal type of program.
Exactly. Yeah, very good. Other questions? I'm looking for any raised hands. You've got an expert right here. Ask all the questions that you need to. So do you have any other ideas coming forth, Sharon? You've got, you're thinking of going to Missouri. Is there anything else that
Well, eventually, I think right now we're going to just see if we can finish up this project, write it up and report it, and then probably bring together a team of other, kind of call up some of the centers in the area and see what they think about joining us in a larger project, probably going to somebody like the National MS Society for funding to evaluate the system. The other, I have to think in terms of who can fund projects like this, and that's going to be one of the challenges. I can foot the bill of a 15 or 20 person program that I'm doing. I can't foot the bill of a multi-center huge trial. Somebody along the way has to help me pay for that.
Exactly. Funding's always an issue. Sarah, did you have a question?
Yeah, Sharon, I think this is really interesting, and I like that you focused on MS because it seems like it's something you not only but you're passionate about. So doing our market research, I know that there are some, it seems like they're more like generalized PT programs or telehealth. Well, they're technology driven, but you're not necessarily speaking synchronous. Well, you're not speaking one-on-one. I haven't had enough coffee today. You're not speaking one-on-one with a telehealth provider. Like Physera comes to mind. Hinge Health, I know, uses sensors. If somebody, and I may connect with you offline to ask a more in detail question, but let's say we wanted to, because we're looking at building out this program in the next couple of years, and funding is something we're looking at, but we would do our target market as employers to help minimize costs. So if we can, lower the rate of presenteeism or absenteeism, then the employer will cover it on a per member per month basis. But just first steps, you obviously would have physician oversight, then you would have PTs that are more generalized. Do you think we should focus on something that's more like MS? Would we do these are lots of really specific
So,
questions.
yeah. Well, I think
Getting it off the ground is kind of like,
Yeah.
I'd like to see what that looks like.
Well, I think that in general, the problem or concern is really about, my concern, and of course I'm a neurologist, is the neuro rehab pieces. So, generally I think in terms of PTs being divided into orthopedic, neuro, and cardiac. Cardiac is a whole different ball of wax. But with the orthopedics, there's a lot of people out there, and a general PT tends to spend a whole lot of time on the orthopedic side of things, knees, backs, hips, and they get really good at that. But when it comes to the neurologic problems, then they're not quite so good.
Mm-hmm.
So that's where the specialist PT kind of comes into play.
Mm-hmm.
Is the idea of someone who is experienced in that. So that doesn't have to be MS. It can be Parkinson's.
Mm-hmm.
It can be head trauma. It can be it can be ALS. It can be muscular dystrophy.
Mm-hmm.
It can be a lot of different things, but basically the idea is the dynamics of the dynamics of a neurologic approach to rehabilitation. And so if you wanted to expand this past MS, what you'd be really wanting to think about is what other neurologic diseases are fairly common out there that we need physical therapy for. I mean, that can even be nerve injuries and things like that.
Okay. Thank you. I really enjoyed your presentation, so thank you all for putting this on.
You're welcome, Sarah. Thank you. We appreciate that. All right, last call for questions. You're a quiet group today. No? Yes, Dean.
Well, I know that it seems like it's really focusing on the physical therapy aspect of it. And this is an area that I really don't know very much about, but I was kind of curious, is if any efforts also being made to share information about like advances for some of the drugs that might be available to offset the continual deterioration of the nerves, and how that plays into it, and if there's going to be an effort to bring some of that in the future.
Well, MS is full of drugs right now. We've got 20 plus drugs, and we've got tons and tons of people who take them. And certainly, the expansion of telehealth to allow for some physician to patient treatment has been greatly expanded by the pandemic. There are limitations on that are just true. There is a certain amount of physical contact required in order for a good assessment to be made on a patient. What I have been doing is mostly focusing on when it comes to my own patient care, is I usually let them get by with it if they're doing well, and I'm just doing kind of a general check, to have them see me by telehealth and allow that for about at least part of the time, but try to see them in person at least once a year to make sure that I do physical assessments that I would otherwise not be able to capture. certainly that can be, some of those checks can be done in partnership with the primary care physician in the rural area instead of my being there. And they have to certainly get blood drawn and things like that, which are going to have to be done locally. But, you know, we have to kind of find a balance here between, you know, having people see a specialist and therefore, you know, seeing them through telehealth because they can't get there, and abandoning the local rural doctors that that are also sorely needed in their care. So finding that balance is sometimes an important issue.
All right, thank you, Dean, for that question. Any other questions? Going once. All right. Well, we are going to be able to give you about 10 minutes back to your day by ending just a little bit early, but really not, because I think Zoom meetings at 50 minutes is good enough, right? We've had a great didactic today. So thank you, Dr. Lynch. That was wonderful. We really appreciate it and know that you are now one of our new friends and contacts in the world of telemedicine. And I think you've got quite a few Missourians on this ECHO. And I think those kind of connections will help you as you move forward as well. Please join us next month, April 13th. Believe it or not, we will be discussing tribal health and telehealth efforts there. And we have a speaker from Oklahoma that's going to help us out with that. So stay tuned, and thank you so much for coming. Next time, bring a friend. We'd love to see more people on our ECHO, and we appreciate the time that you've given us. So thank you. Go out and make it a great day.